Okay, this is President Hughes. I'd like to call the Maricopa County Board of Health meeting to order. And can we do a roll call, please?
Yes, good morning, everyone, members of the board. This is Vera Sampler. I'll begin with the roll call. Don Casano.
Present.
Robin Schaefer.
Present.
Robert McMillan.
Present.
Christian Axton. Andrew Rescon. Paula Bonahan.
Here.
Scott Seeley. President Hughes.
Here.
Dr. Baldoff, Deborah.
Present.
Dr. Stander. Supervisor Bill Gates. I'll do a recall. Christian Acton, I know is not present. Scott Seeley. Andrew Rescon. President Hughes, I've completed the roll call. I have 6 members present. I believe we have a quorum.
Great. Is there anyone from the public that wanted to address the board at this time?
There are no hands raised at this time.
Okay. Can I get approval of the July 27th, 2020 Board of Health minutes, please?
So moved, Mr. Chairman.
And a second?
I second.
It's been
This
moved
is
and
Vera. I'm sorry, for record keeping, can you please say who's pulled the motion and who's second?
Don Casano made the motion.
Deborah Baldoff seconded.
any comments or changes to the minutes? If not, all those in favor say aye. Aye.
Aye.
Oppose? Minutes carry. And Scott, can we go to the public health finance update, please?
Yes, Mr. Chairman. As of through September, or 25% of the fiscal year, we have spent 20.5% of the general fund authorized budget, with a year-to-date positive variance of $805,000. In personal services, we have a positive variance of $485,000, or 16%. We currently have higher than usual number of vacancies in the general fund. However, it is the reallocation of payroll to the CARES Act funding for those staff working on the COVID-19 response that accounts for the largest share of the positive variance. For supplies, there's a positive variance of $636,000 year to date. This is due in part to the slowdown in normal spending as a result of the COVID response, but the larger share of this is in the lab, where lab supplies purchases are running well behind year to date, which is partly the result of a delay in getting a contract renewed with one of our major vendors. In services, there's a negative variance of $144,000. The Office of Vital Registration recently received a general fund appropriation of $476,000 for taking on the function of indigent decedent services. This will be an ongoing funding, and more on this under Fund 200 below. Last year, as an FYI, we began using objects 8740 and 8750 to code indirect and the admin costs reallocated to the indirect. That shows on the report, the worksheet that you received as the last subtotal for each of the funds.
Scott, this is Marcy. I'm so sorry to interrupt you, but I just want to let you guys know that I just got a text message from Zach and Supervisor Gates. It seems that there's people that have called in and that are on hold just hearing music.
Oh.
Whatever number was sent out. So if we can try to address that.
Thank you, Marcy. We'll look into it right now. They're probably using the old April, like Ken called in.
Is there a way, Marcy, is there a way for you to contact them back? Could you give them the correct number, Sarah?
He said that both Bill and Dr. Stander just have music playing. So do you guys want to give me a different number for them to call? But they're both on hold trying to get into the meeting. And they called the number that was sent out on the invite, they said.
That's the old number. Can you call us on the thing, Rebecca?
Do we have to
Actually,
admit them into the
David?
meeting?
David, would you please reissue, go out to the dashboard and reissue to those two individuals their call-in information?
Yeah, it was Commissioner Gates and who was
Dr. Stander?
Dr. Stander. Okay, got it.
Thank you, sir.
Should I tell them to check their emails?
Yes, when he reissues it, their invitation will come back via email.
Okay.
Would you like to wait a few moments for them to get in?
So I just told them to check their emails. So I don't have Dr. Stander, Vera, if you want to reach out to Dr. Stander, but I'm texting with Zach right now.
Those emails were resent.
Thank you, sir.
Should give him access.
They're looking at an old calendar.
They use the old invite instead of this one.
I'm just gonna say one sentence about general fund and now approval into the two, no, just leave it at 200. It's about 200. Yeah, okay.
Marcy, can you check with Zach to see if they're able to get in now?
Oh, that's 602. Did you text them?
Who are you trying to text? We should see Supervisor Gates and Dr. Stander pop up if they are able to get in.
Yeah.
We should have just received, I'm sorry, you should have just received an email that will immediately get you into the meeting. Yeah, I'm sorry about that. You're probably using an old calendar invite maybe that had an old number on there. We're now with virtual. My apologies. Just now, maybe try refreshing your screen, do F5 if you wouldn't mind. And you should have an email and you'll have a join button in the email.
I haven't heard back from Zach yet.
Okay. Like Scott Seeley has joined the call as well.
Yes, good afternoon.
Hi, Scott. Just want to be sure that you're registered and we know that you're here.
Thank you. I did have some audio problems as well, but
Supervisor Gates has now joined.
Good afternoon.
Good afternoon, sir.
Rebecca, did the email go to P Standard? Did you say at Gmail?
David, would you check to see the email went to p.standard@gmail?
He has two emails.
He has
It was
two
a diff-
emails.
It was a different address, so I can change that.
Was it Paul.Standard?
Was it paul.standard
At VA.gov.
at VA?
It was paul.stander@va.gov is the one that got sent. Do you,
They're sending it right now, Dr. Standard. If you can send it to PEStandard@gmail, he would really appreciate it.
Did you catch
And it
that,
looks like
Dave?
Supervisor Gates was able to join.
Yes, Supervisor Gates is in. And Scott Seeley is also in.
If you can click join, sir, then you will join the meeting.
Mr. Standard is almost here. He has his message.
can you repeat the email he needs? The one at Gmail?
P-E
Standard
Standard.
at
So
Gmail.
P-E-S-T-A-N-D-E-R. Okay, P as in Paul, E as in Edward, S as
Sent.
in Sam,
Got it.
okay, @gmail.com.
Son is-
Yep.
heard something. Is that a good sign? Okay. Yep, should be a blue bar. Okay, you going through, doctor?
Okay.
Okay, I'll just wait to make sure. I'm gonna mute my phone so you don't get the feedback, but I can hear you, sir.
We're just waiting for Dr. Standard to make it in.
Okay.
Okay. We should see him coming through now.
Yeah,
There you go.
Here he is.
We hear you, sir. I'm gonna hang up the phone line, okay? Thank you. You're welcome.
There you go.
Okay, sorry about that. We're ready to presume, President.
Okay. Scott, why don't you start over?
All right. So for the general fund year-to-date through September, or 25% of the fiscal year, we spent 20.5% of the general fund authorized budget, with a year-to-date positive variance of $805,000. In personal services, the department has a positive variance of $485,000, or 16%. We currently have a higher than usual number of vacancies in the general fund. However, it is the reallocation of payroll to the CARES Act funding for those staff working on the COVID-19 response that accounts for a larger share of the positive variance. In supplies, there's a positive variance of $636,000 year-to-date, due in part to the slowdown in normal spending as a result of the COVID-19 response, but the larger share of this is in the lab, where lab supplies purchases are running well behind year-to-date. This was partly the result of a delay in getting a contract renewed with one of our major vendors. In services, there's a negative variance of $144,000. The Office of Vital Registration recently received a general fund appropriation of $476,000 for taking on the function of indigent decedent services. And this will be ongoing funding, and more on this under Fund 200. Any questions about Fund 100?
No, I don't have any.
Fund 200, which is the Coronavirus Relief Fund, CARES Act funding. This is the main fund for the COVID-19 Response CARES Act, and as of July, most of this fund's activity is going through the new Department D890, the UCC, created for the response. However, some of the costs are remaining in our department, D860, Public Health. The total spending in this fund year-to-date is $1.35 million, which is just over the budgeted $1.34 million. But I should point out that the budget for the CARES Act funding is adjusted to the expenditures as we go along, so that's not a fixed amount. For the first month or two of this fiscal year, several $100,000 of PPE purchases still posted to our portion of this fund. But going forward, most of these purchases are posting to the new department, D890, the UCC. In personal services, most of the $386,000 in expenses to date were for 3 months of emergency leave for department staff who were unable to work due to COVID-19 restrictions and child care responsibilities at home. And most of our staff, by the way, have been working remotely and are being paid through their normal funding sources. The Office of Vital Registration has been fully funded through the fee fund until recently. However, the program recently took on the function of County Indigent Decedent Services, SIDS, which had been provided by the Public Fiduciary Department before this. For the next few months, a share of the staffing and contracted services for this program will be paid from Fund 200, CARES Act, due to a share of the COVID-related deaths having been in the indigent and homeless population. As noted above, the department also received a general fund appropriation of $476,000 for the ongoing work, and will need additional resources for this ongoing program once the CARES Act funding is discontinued. And I should note that generally, we don't see revenue in the general fund, but in this case, there will be revenue generated from sales of property of the deceased indigents when all other avenues have been exhausted to find the other related family.
Scott,
Yes.
when you say general fund, is that county general fund money that we're talking about for the indigent, for Office of
That's
Vital?
correct. And so if revenue goes into the general fund, it just goes into the county coffers. It doesn't stay within the public health account.
Okay, thank you.
Any more questions about Fund 200? All right, we'll move on to Fund 265, the Special Revenue Fund. And from this fund, we spent 15.6% of our expenditure budget as of the end of the first quarter. Actual expenditures are under budget by $796,000 or 38%. This budget consists of $7.6 million in operating funds and $500,000 of non-recurring funds. Only $12,300 of the non-recurring fund appropriation has actually been expended to date. The non-recurring funding comes from the fee fund balance of unspent funds and revenues over the years. Personnel expenditures for the fee fund are $149,000 under budget year to date. Supplies expenditures are $546,000 under budget, which is largely due to the $1.5 million of vaccine purchases made so far being reallocated to the CARES Act funding, which shows as a large credit to the expense line. Services expenditures are under budget by $144,000. Fee revenues year to date are exceeding budget by $79,000 and are exceeding expenditures by $729,000, so the fund is more than structurally balanced. Fees for the community health assessments that we do for the hospitals are $39,000 below budget year to date. Revenues are below budget due to one hospital chain pulling out of the program, at least for this year. And revenues are not expected to cover expenses this year. We hope by next year to be structurally balanced in this account. I believe, was it Banner that didn't sign up this year? The Banner hospitals, yeah. Next year, we hope to be structurally balanced in this account. And last year, the program's expenditures actually were about $40,000 under revenues, so they contributed to the fund balance last year. Third-party collections for the immunization fee fund are coming in behind budget by 21.4% due to the COVID restrictions in the first part of the year. They expect to make up some of this with their new call center, which will remind clients of their appointments. For vital registration, revenues year to date exceed budgets by $201,000 and exceed expenditures by $323,000. The pharmacy account, which is primarily purchases for and credits from the user program, shows a $713,000 credit balance due to large reallocations to the CARES Act program for flu vaccines and delayed billing from the vendor. The TB fee fund revenue is $17,000, almost $18,000 under budget, and is short of covering expenditures by $33,000. The primary reason for the revenue shortfall, they've been issuing a lot fewer of the $65 TB cards that restaurant employees are required to get, and of course that has been down in the last several months. The TB, 12,000 of the expenses in TB are for additional software for the program's digital X-ray equipment. The STD fee fund revenue is almost $50,000 or 48% ahead of budget year to date, and revenues are $56,000 over expenditures. COVID-19 does not seem to have slowed down this program. We've reported previously that the refugee fee fund expenditures have been cut dramatically. The program is maintaining the minimum core staff necessary to keep the program going. To date, however, fee revenues are only 8% under budget with the right sizing of the expenditure budget for FY21. And they are $10,800 short of meeting expenses. Any questions about the fee fund? For the Fund 532, the grant fund, through the first quarter, grant fund expenditures are $4.5 million under budget year to date. Revenues to date are 2.7 million below budget, which is 20% below budget. As we pointed out before, all of our grants bring in enough revenues to match expenditures before they can be closed out. However, these numbers point out the substantial impact that COVID-19 has had on some of our grant operations and resulting collections. Our WIC grant has been able to keep up with clients by working remotely, as have our Ryan White programs. However, grants such as the oral health and dental sealant grants that depend on schools being open have been hit hard to date. And that is all of my report. Any questions on the grant fund or any other questions?
No, I don't have any questions. Does anyone else have any questions for Scott?
No, I don't have any questions. This is Paula.
This is Don Casano. No questions.
No questions from Bob McMillan either.
No questions from Robin Schaefer.
No questions from Deborah Baldoff.
Or Scott Seeley.
Thanks, Scott. Gus?
Yeah, he said he was on the line.
Yeah, but he's not unmuted.
Okay.
There you go.
Gus?
Mr. President, members of the board, are you able to hear me?
Yes. Yes, go right ahead, Gus.
Thank you. Mr. President, members of the board, Environmental Services administers three funds. Fund 100, that is our county general fund. Fund 290, that is our environmental tire fund. And finally, Fund 506, which is our environmental fee fund. I'll be going over the revenues and expenditures in each one of those funds and then allowing time in between for questions. Jumping right in, Fund 100 is reporting revenues at 81% over year-to-date budget and expenditures at 10% under year-to-date budget through period 3 close. Fund 100 is primarily, the revenue sources are fines and fees for unpermitted locations or establishments. And the second source is, they are transfer station fees for refuse collections. And so currently we're reporting $155,030 over, which is 81%, or we're reporting $155,000 in total collected, which is 81% or $69,000 over year-to-date budget. And that's primarily due to folks being at home for the COVID-19 pandemic. They're generating more trash, they're making more visits to our transfer stations, and thus we're collecting those revenues. The second portion of that is that we just implemented phase 2 of our transfer station fees increase on August 1st. And so we're starting to now see that revenue come in. Expenditures are reporting at 10% or $268,000 under year-to-date budget through period 3 close. That amount is primarily attributed to a variance in supplies and services in the amount of $236,000. Again, this is goes back to our historic low rainfall that we've seen here in this last monsoon season. So we have not been able to, we have not found the need to purchase chemicals for vector control. We typically do that in the first quarter. So we're still having a large carryover of chemicals from the last year. Any questions on Fund 100?
Nope.
Moving on to Fund 290. 290 is our tire fund. We're reporting revenues at 5% over year-to-date budget, and our expenditures are 7% under. Fund 290 is funded by the state's tire disposal tax, and those revenues that are collected by the state are distributed to the county based on the number of vehicles registered in that county. And so we received our first payment from the state in the amount of $1.5 million, which was 5% or $78,000 more than expected for our first quarter. Finally, the expenditures on that side, which are typically are primarily used for recycling tires, was $78,000 under budget. We don't anticipate to remain under budget in this this fund. Typically in June, we end up receiving a large bill. So all of these variances will be carried forward and then eventually used up later on in the year. Any questions on Fund 290?
No, this is Paula Banahan.
And okay, Moving on, last is our environmental fee fund, Fund 506. It's reporting revenues at 7% under year-to-date budget, and our expenditures are 13% under year-to-date budget. These revenues they come from our permits and plan review fees associated with restaurants, septic systems, waterway systems, and various other activities that we have under the fee fund. And so we're currently reporting 7% under, which is $410,000 under year-to-date budget for those. So pools and food permitting are still experiencing impacts from the COVID-19 pandemic and the related executive orders issued by the state. The hospitality industry continues to be impacted from temporary closures, limited dining capacity, and overall decline in business, which has led to an increase in our delinquent annual permit payments. In April and then again in October, the Board of Supervisors adopted a resolution offering permit holders financial relief by allowing permit holders to pay their permit fees in installments. To date, over 300 permit holders have already opted for this relief. And throughout the pandemic, the department continues to provide full service to these folks. And so what that means is we're going to start seeing a delay in when our revenue comes in now that folks are allowed to have installments. So typically we would see a full payment made in October. We might see a partial in October, a partial in November. It's our hope that this relief will still allow businesses to continue to flourish as well as collect our revenue. So we're always going to be a little bit behind throughout the year.
So is it 2 installments, Gus?
Previously, it was 2 installments, and the newest resolution has allowed up to no less than 8%. So in essence, we're allowing a 12 installment plan.
Okay.
And then finally, our expenditures are 13% or $785,000 under year-to-date budget. This is primarily made up of personnel. We originally budgeted for a PFP in FY21 that did not get approved. So those monies that were budgeted for are always going to show that we're under budget because we're not using them. And then secondly, we're only hiring and we're responding to COVID as necessary. So more restaurants open up, we would expand hiring. So in the beginning, we went to a critical hire model only. However, we're starting to see businesses reopen back up. So we're currently, I think we are under about 15 vacant positions are currently under recruitment. And so we're responding accordingly. If you go ahead and take a look at the charts, you'll see that Fund 506 is relatively still structurally balanced. I think it's about 30. The revenues are about $30,000 less than expenses. However, Fund 506 maintains a $13.6 million fund balance that we could draw from in the event that our revenues go any lower than they are right now. Any questions?
No, this is Don Hughes now.
None from Don Casano.
None for Robert McMillan.
Well, thank you. That wraps up my report. I think we're going to call in, right? Ken and Darcy will be calling in shortly.
Okay. So we have Marcy next up on the agenda for public health report. Or are we waiting for Darcy and Ken?
Marcy is next on the agenda, please.
You don't need to wait, Don.
I was going to say I can go. I don't need to wait for Darcy.
Okay, let's go.
Okay, so good afternoon, President and members of the board. I'm going to first go over some of our latest numbers and then walk through some highlights. So change as of yesterday, we had an additional 688 cases reported. So that brings our total right now in Maricopa County as of close of business yesterday to 154,902. We still see the majority of our cases in that 20 to 44-year-old age group. And most recently, our newer cases have been in the 0 to 19 and that 20 to 44 age group. So that's about 20% is in the 0 to 19 age group that we're seeing recently, and 43% in that 20 to 44 year old age group. When you look at our deaths, we had one additional death yesterday. That brings that death total to 3,539. We still are seeing our hospitalizations hover right around 8% and ICUs around 1%. Also, what we're seeing is an average of 700 cases per day over the last week, and this has been steadily increasing. Our case rate is now at 69 cases per 100,000, and that's up from 52 cases per 100,000 the week prior, which still keeps us, though, in that considered moderate spread. Our percent positivity is at 5%. It appears to be slowly increasing, but again, this 5% still puts us in the moderate spread. And our hospitalizations are steadily increasing, but slowly. And the faster increase has definitely been in the medical surgical beds rather than the ICU beds. With me mentioning the death just going up by 1 yesterday, our deaths have not been increasing, but we expect to see this as a lag by approximately a month from when we see the initial increase in cases. And this last sort of uptick in increase in cases started at the beginning of October. So if we were to see an uptick in our deaths related to that, it would probably be the first week or so in November. 83% of individuals that have died from COVID-19 are age 65 years or over or have a chronic medical condition. You've heard a lot recently, I'm sure, about school outbreaks and what's been going on in our schools. We've had 34 school outbreaks, and an outbreak has a really low threshold. So I want to explain that for a school, an outbreak is just 2 or more cases where the likely source of exposure was related. And so we've had 34 of those outbreaks. 106 students and 43 staff have had an exposure at school. With the schools, we're working really closely with them. It was announced on Friday that Madison School District did close down for 14 days. That was not at the recommendation of public health. We had been working with Madison with their 4 cases they had. We didn't recommend that they close down for 14 days. That was a decision made by the school, but we do work closely with all of the schools, especially when they reach out to us and let us know that they are considering closing down or doing some other sort of strategies that would, shut down the schools or limit students in classrooms. What we're still seeing in the majority of our cases that we are seeing in schools is that the exposures are happening at events that happen outside of a classroom. So the schools have done great jobs, I believe, in putting strategies in place to cohort, limit students' interactions with one another, do as much social distancing, certainly wearing masks, having faculty wear masks. And so although these are students and it affects the school, a lot of times it's activities outside of the school and things that the students have done on the weekends or on family vacations or those sorts of things that have led to them contracting COVID-19. So when we talk to a school about the cases they're seeing and make any recommendations about whether they should close down a classroom or a school or anything, we really take a whole bunch of factors into consideration. Everybody's been curious and wanting to know what is that magic number or threshold or percentage at a school of positive cases that would lead public health to recommend closing a school. And we're really hesitant, and I don't think there's an answer to that question, simply because every school is so unique. So we take a lot of factors into consideration. When you, for example, look at the schools in Pinal County that closed, they had very few cases But what had happened at those, at one of the schools in particular, was that it had led to a quarantine of several hundred, I believe around 400 students and faculty were having to quarantine because of that small handful of cases. And they just didn't have enough teachers for their classrooms anymore. So that's when the school really had to close down and, do that time where they just had to go back to virtual. So that's the message we continue to share with the, with the media and the public. And if there's any message to give to parents right now, it really is, think about the things that you're allowing your students to do on the weekends and outside of class, and just weigh those risk and benefit of those activities. Encourage your student to wash their hands often, sanitize if they aren't able to use soap and water, wear their masks, stay home where they're sick, all of those same things that I'm sure everyone's getting tired of hearing us say, going on nearly 11 months now. So those are all of my updates, and I can take any questions from the board.
Marcy, it's Don Hughes. What's driving the increase in cases over the last, 3 or 4 weeks? Is it primarily that they've gone back to school? Are we seeing other problems? And can you comment what's going on with nursing homes? Since that's one of the primary high-risk groups.
Absolutely. Thank you for that question, President Hughes, members of the board. So, we believe what's happening right now is you can't pinpoint it or say it's one thing. It certainly coincides with a lot of things happening around the same time. We had universities go back in session. We had some schools and more continue to go back in session. You have more employers that are allowing employees to come back into offices, more employees that are going into work. You have some of the strategies allowing more, gyms and restaurants and bars and things to open. And, one of the things we're finding when we do our case investigations is, there's a term out there, and I certainly believe it to be true, is this notion of COVID fatigue. And I think what's happening, especially as we near the holiday season, we've been a long time in this state where we're asking people to socially distance, stay home as much as possible, go out only when necessary. When you go out, wear your mask. I think as we head into this fall season, we're just having a lot of people become a little lax with going to events. Fall break, we certainly, in what we're seeing in the schools, a lot of the numbers are associated with activities that families did for fall break and places that they went during their fall break. So it's really, we believe, just a combination of all of those things. And our most important message to get out there to everyone is, unfortunately, we're still in this pandemic. Now is the time to be vigilant with washing your hands, staying home when you're sick, wearing your mask, all of those things that everybody has heard a million times, and that really, get us through this holiday season, and to hopefully where a vaccine becomes available, we can start really targeting some of these high-risk populations in these areas, like our healthcare providers, first responders, those sort of things. And as far as the long-term care facilities, because they were one of these early on unfortunate, institutions that experienced COVID, there was a lot learned. And so our long-term care facilities, we continue to be in constant communication with them. They have received a lot of PPE resources at the local and federal level. We've also been able to get them a lot of resources for testing. And the state also has resources available now for these long-term care facilities that have the need for individuals to go in and help them conduct testing. So that has all been really good. We haven't seen the outbreaks at the long-term care facilities like we were seeing early on, which is a really good thing and a really good sign.
Great,
Dr.
thanks.
Don, this is Don Casano. I have a question also for Marcy.
Sure.
Marcy, concerning the double whammy we may experience with the flu, how are the flu vaccines going? Are we seeing a real uptick in people getting those now based on all of the public service announcements and the push by the pharmacies to get them?
Yeah, thank you so much for bringing that up. Mr. Casano, members of the board. We have seen an interest in the flu vaccine initially go on an uptick, but we have seen that come down. We haven't seen the continued interest in getting the flu vaccine. We still are setting up flu vaccine clinics. As much as you want to help us get that word out and encourage folks to get their flu shot, look on our website to see where we have, flu clinics happening, flu shot clinics. They can go and have a free flu shot if they can't pay for it or if their insurance doesn't cover it. We don't want cost to be a reason that someone doesn't get their flu shot, but absolutely, as we head into these fall months, November and December is really when we see our surge in flu, and then we reach our peak in those very early months of a new year. So January is usually our peak for flu. So now is the time to get your flu shot, and you're absolutely correct. We're keeping close communication and watch on our hospital partners because the most important thing right now is that we don't get back to where we were early this summer when our hospital systems were really struggling for staffing and had to eliminate or really decrease the amount of elective surgeries they were able to do. We certainly don't want to get back there. So the hospitals have felt the increase in numbers, but they have also said it's not to where it was earlier this summer. So all of these messages about the basic mitigation things we have in our toolbox that each of us can do, but also getting your flu shot is going to be really important.
Thank you.
Marcy,
This is Dr. Stander. I was just going to say, it's hard to track exactly, people's sentiments. I know all the healthcare systems have mandated healthcare workers getting flu shots. It's a good thing. Speaking for my own population of patients, I mean, everybody, certainly the senior group, is all getting it. And it'll be interesting, I think, you may confirm this, Marcy, but like in March, at the beginning of the pandemic, which was the tail end of the flu season, flu cases dropped off pretty dramatically with the social distancing and hand washing and good behaviors. So obviously, I'm not saying we should dissuade people from getting the flu shot, but it may paradoxically be a little bit mitigated by all the COVID precautions. We may be able to avoid a really bad flu season as well as, on top of the vaccines.
Absolutely, Dr. Stander. Thank you for pointing that out. We actually did see that, you're right, at the tail end of flu season. And actually year to date, we've had 12 cases of the flu reported to us, which is lower than what we had previously last year at this time. So we are seeing that a little bit, and people have asked us, is it the masking? Is it the social distancing? It's probably a little bit of all of those things. So that is going to help as we continue those things. It may help with our flu season as well. You're absolutely right.
Hi, this is Robin Schaefer. I also want to make a comment and an observation. Marcy, first of all, thank you for that report and all the great work that the county is doing on this. I just want to reiterate, as someone that represents nurses and the voice of nursing in the state, that you called it COVID fatigue and we call it COVID it out, because even the nurses are tired, but we are still recovering and have tremendous burnout and secondary trauma that's been documented, and we're focusing on the mind and body of the nurses. I can tell you that the anxiety level is high of nurses when we start to see the numbers creeping up, and just want to stress that we really have to focus on the community spread mitigations. And, I myself, when I go out to a grocery store now, see some people not wearing masks. And, I just want to run up to them and, scream at them. But, I think, like you said, it's not a time to let down our guard. And, I'm hoping that there's some messaging coming out from the county. I know that the nurses are speaking up about this also, about the importance of wearing masks. But it's a lot of anxiety and stress, probably for the doctors too. Dr. Standard can also speak to that when we start to see the numbers creep up. So community mitigation and spread are just so important. And thanks for all the work that you're doing.
Thank you so much for that. And I couldn't agree more. I think that there's a little bit of, from the summer, PTSD in all of our staff, especially our EPIs and our, individuals, our nurses that are doing the case investigations. And my sister's a nurse and works in the Banner system. And certainly she calls me, we talk on a daily basis, but she tells me people are getting a little nervous. And, I think it's a good point. And tomorrow I have a call with ADHS. We speak twice a week. And after some of the conversations I've had today on several phone calls with community partners and the media, I'm really going to push that they have a campaign that's promoting and masks but I think it's important to acknowledge that we're coming up on the holiday season, and it's going to be a trying time for all of us to rethink how we have our holiday season in a safe manner during a pandemic, and maybe some good messaging or PSAs or anything that can kind of really acknowledge that we all understand how everybody's feeling, but now is not the time to throw in the towel and say I'm done with limiting my gatherings and not wearing, and wearing a mask and all of this. I'm just done with it. Now's not the time for that. So, I mentioned it on a call to someone today that from what we're hearing from the CDC, it really sounds like there may be this first phase vaccine by the end of this calendar year. And I think that's going to be so important, because I think it'll be that first little pin of light that we can see at the end of a tunnel. Even if it is for a very small portion of the population, the initial vaccine will go to. It's what we need to be able to show people that there is a light at the end of the tunnel, but now's not the time to say we've made it and that we're over anything by any stretch of the imagination. So thank you for pointing that out.
Marcy, is that first vaccine likely to be a 2-dose or a single dose?
So from what we're hearing, if this turns out to be the vaccine that goes, it will be a 2-dose vaccine. And it is very, what we're planning for is a vaccine that is very, what I would like to say is temperamental or fragile. It has a lot of temperature controls, has a lot of how quickly you need to use it once your diluent is mixed. And so if that's what we're looking at, we've got tons of planning and stuff in place to deal with it, but it will be, from what we're hearing, a 2-dose vaccine.
Separated by what time frame? Like a month or 6 weeks, or
That we have not heard that yet. They have not told us that.
Because obviously that complicates, distribution and compliance and effectiveness and all that stuff.
Absolutely. And the other thing that makes this vaccine a little unique is that it has to have ultra cold storage, which is below freezing, and not everybody has that. So we're planning on that. We're also planning on, very limited how much you can open up the shipment that the vaccine comes in. Again, like I said, once you add the diluent, we've heard as little as you have 6 hours to use the whole vial, and have several hundred people through that one vial within 6 hours. So all of that planning is happening right now, and I feel really good about where we are going with that.
Okay.
Yep, Marcy, Bob McMillan, please. Here's a question. How important is the antibody treatment in reducing the mortality rate now? And how available is antibody treatment for those that may need it?
So I had a little bit of a hard time hearing you. Were you talking about the antibody testing?
No, there's, as I understand, in fact, the president was given this. It was an antibody, a serum, I believe, of maybe other people's antibodies that he was injected with that gave him temporary immunity to the disease itself. Can you explain what happened there and whether that's a relevant thing that's being used now for reduction of mortality?
Right, now I understand what you're saying. I'm sorry. So actually last week, what did happen was that the FDA did just come out with the first, what they considered the FDA approved treatment, remdesivir, and that was an approved, and it's an antiviral drug. So it's not antibody, it's an antiviral that's given. And it's for adults and pediatric patients that are 12 years and older. And then there's a minimum weight that they have to have, but it is the first one that the FDA approved for treatment. What that means is that it doesn't mean it makes someone immune, or it doesn't mean that they won't get or receive COVID. It's similar to, when someone says they have the flu and they were given an antiviral, it doesn't mean that it's going to prevent them and the flu's going to stop. It means that it should lessen or even kind of reduce the effects so that it's not quite as difficult of a COVID-19, as what you would see. Maybe it could shorten the duration of your symptoms. It could have your symptoms be a little lighter, a little easier than without an antiviral treatment. And that's really what's been approved, and that's what was given to the president.
No, but Marcy, just, I think to the other point, he did also get a product made by Regeneron, which is a monoclonal antibody or a pooled antibody from, from donor blood and things, people who've been it. That still is not officially approved or uniformly been proven to be
moving it around.
So he did get that, but because he's the president. And when he said, the next day I was feeling better, I don't really think that's probably true. But and how much it did or didn't impact his recovery, who knows? Because it's, as they say in science, it's an N of one. He got it, but he also got the remdesivir and he got dexamethasone, and how much, and he recovered. Whether he would have recovered equally as quickly or not without all this, it's again, only proven treatments, as you just said. Remdesivir may shorten the course. Dexamethasone reduces the people of going on to ventilators, and probably some reduction in mortality. So I think the answer to the other question is that antibody treatment is not officially approved or uniformly available.
Gotcha. Thanks for the help on that. And one other question too, as far as temperature, if we went back to being as careful as we have been and we didn't have the COVID burnout or COVID overdose, then would you expect the temperatures to play a significant role in the increase, the uptick during the winter months? Can you explain, what the concept is that how much of this is probably due to temperature versus these other factors of schools going back to resuming schools and such as that?
Yeah, from, evidence that's been seen in other parts of the world, early on, everyone was thinking that, temperature may have places that were super hot, maybe weren't seeing as much initial spread because of it being really warm. Other places were saying where it's cold, it's not as easily spread. I think what we've learned is that more than temperature, it really has to do with close contacts and, the less ventilated. So, when you just think through places like Arizona in the summer, we're usually more indoors for the air conditioning. And so that's when we are seeing some of our higher numbers. Not that it's totally correlated to that, but you know, in the winter months, for us to spend more time outdoors is going to be a good thing, I think, for our numbers. So I'm appreciative of our nice fall and winter weather we have here. Whereas you see in the Midwest, it's starting to happen, their numbers go up. And I certainly don't want to correlate any of that to just the temperature, but there hasn't been anything to say that this is what we're going to see in the winter months versus the summer months. Flu kind of follows a seasonal thing, but COVID just really hasn't been as predictable as the flu to follow some sort of seasonal. I think if we were going to see that, we would have seen something from when we initially saw COVID hit the US and very early in 2020. But as you've seen, it's kind of been this roller coaster, not dependent of following seasons of up and down numbers.
Gotcha. Thank you, Marcy.
Mr. President,
This is Paula Banahan. In going along with the reports that we see from you wonderfully every single day from Vera, and the 5% positivity, I'm assuming that's the serology, the blood test. And it doesn't really, as you know, correlate with the swab test, which is usually higher. So
No, that isn't, excuse me, I think that isn't the blood test. Those are the swab tests, aren't they? The percent of people getting the PCR test, what percent are testing positive? Isn't that true, Marcy?
Yeah, so if I can just let you both of you, the percent positivity is what we are able to capture based on data from ADHS. Unfortunately, a few weeks ago, ADHS used to base percent positivity on the CDC guidelines and recommendations, which is strictly PCR tests. And so that's the nasal swab. That's the kind of gold standard for testing right now. However, they did just a few weeks ago change that. That percent positivity now includes antibody testing, antigen testing and PCR testing. So it is those rapid tests and PCR tests that are included now in the percent positivity.
So when we get the reports on a daily basis, I always went down to the bottom. I thought it said clearly that the blood tests were always much lower than the swab tests. Does it have a more accurate positivity rate than, I thought that the swab test was about 50 to 60% positive or accurate. Is that still the same?
So you're talking about actually two different things. So the blood test that you're talking about, that is a test when you're talking about a serology test, and that is lower. But what a serology test is doing is it's just telling someone if, in their blood sample, they had detected that person, either at IgM or IgG has had COVID in their symptoms or in their system. It's checking their serology. The other test that you're seeing that's a little bit higher percent positivity, that's a diagnostic test. And the diagnostic test is telling someone if they're currently infected with COVID. So a serology test is telling someone if they've had COVID and if they have, hopefully antibodies in their system. And the other one is diagnostic to tell you if you're currently infected with COVID. Do you understand the difference?
I do now. I did not before, but that
also, Paula, just to add on to what Marcy just said, there's a difference between what Marcy just said about the accuracy of the test is all valid and what you're looking for. But remember, one of the things that you want to really be able to get a sense of is what's the prevalence in the population. If you just tested if you had the ability to test everybody at any given point, you'd get some sense of the prevalence in the population. The PCR test is typically done for people who either have symptoms or had a contact. So by virtue of that, it's a little more likely that it's going to have a higher percent positivity just because you're targeting a different population. A lot of people are just, who are getting the serology test, are just curious, have I ever had it before? You know, they're not currently sick or something. So don't confuse the percent positivity necessarily with which one is more accurate, and also what they're testing for different things. So I think when the prevalence of the PCR test goes higher, it generally means that there's more COVID in the population, even of people who aren't being tested. That's why, they want those PCR tests to be under, 5% or so before they relax, restrictions and so forth. Does that make sense?
Yes, that makes perfect sense. Thank you
Okay.
very much for that clarification. I was confused about it. That's why I wanted to bring it up. Thank you.
Okay.
Mr. President?
Yes, Scott, go ahead.
Okay, and Marcy, thank you again for your report, and also for all your team is doing. I did note the 386,000 or something in leave time that people have taken, which is a good thing. I'm glad people are getting a break at the department from time to time, and I hope that you are among them. But a couple questions following up on this, the last explanation there. And I recall a month or two ago, maybe, that the department was doing kind of, I'll say, a randomized test in different communities around the county and so forth to try to figure out, because we're approaching, it looks like 250,000 cases that we know of. But what's the best guess at this point of what portion of the public may have had COVID and were asymptomatic, and we don't know how many of them there are at this time?
Yeah, thank you for that question, Scott. That's a great question. If you do remember, just approaching next week, I believe we'll be approaching a month ago, we did a sero survey, and that was in partnership with ASU and with the Mayo Clinic. And we did this with a methodology by the CDC, where they helped us identify different locations within Maricopa County. And we had to get so many participants within those locations to participate in the sero survey to give us a confidence interval of what our percent of individuals in the community that have some antibodies or immunity to COVID-19 and what that looks like. So our team is still working closely with ASU. We're really hoping by next week we can come out with some of that data and those numbers. And what that's going to tell us is, for example, we've seen studies in other parts of the world where they believe that, for most communicable diseases, we like to see our percent of the community that has immunity, that is either through a vaccine or having built up natural immunity by having the disease, around 80–90%. With COVID, the good thing, if this turns out to be accurate, is we've seen somewhere closer to 40% could have some really good benefits on a community for having low community spread. And so if our sero survey comes back and tells us that 10% of the population in Maricopa County has antibodies or immunity to COVID-19, that gives us kind of a jumping point to say, we know we'll need at least 30% more of our community to receive a vaccine, for us to really be able to say that we have low spread of COVID-19 happening in Maricopa County. So hopefully those numbers, like I said, and a report and information, we said it would take just about 30 days from when we started the sero survey till the end, where we were able to release some numbers and data and information. We finished up just about 2.5 weeks ago. And so next week, I know the team had some preliminary work and numbers, and they were finishing up trying to get it. But the great thing to know is that We did hit our target and reach the amount of participants we needed. We submitted that to the CDC. The CDC approved it. They did say that this would be considered an accurate picture, and kind of the results would be representative of all of Maricopa County. So those were some of the first things we wanted to make sure. And now they've kind of moved on to the next parts of how they break down all the numbers and results that they got.
Okay, so I guess I'm just quickly, based on that, the CDC conversation stuff, is there a number of, that people are thinking beyond? So if we're at 250,000 roughly in Maricopa County, we're approaching 5% of our total population has been infected that we know of. Are they guessing that, you know, that's only half of the number, or that's a quarter of the number that may actually have? And I know it's a guess, but what's the CDC working with as a kind of spitball number?
They're not really doing that. They're waiting for our results of our sero survey, because what's kind of happened in other communities when they've tried to guess that is that after they do sero survey results, there hasn't been a real, you know, good indication to say if we're saying that, you know, in Arizona, you know, the numbers we've had, or in our particular county, the numbers we've had should result in about this much of the population already having some immunity. The numbers just haven't worked out that cleanly. So each community's been a little bit different, and that's why the results of our sero survey are going to be so important.
Okay, so just in part of what brings this to mind for me, I remember, you know, patient 0 or whatever back in was it late February 28th, I think it was an individual who was asymptomatic, right? But came in to get tested because he was a little paranoid about whether he might be sick or not, which, as we know, was at ASU. So leaping to the universities then, and this is, as Paula mentioned, the daily reports are really appreciated, and the information in them is fantastic for everybody that contributes to that. It has seemed to me here recently, matching up what the universities, and I'm talking both Pima County, which you know, as well as Maricopa and ASU, that if you put the numbers that are being reported by the universities up against the county-wide figure, it seems like a rather large percentage of our total positive cases are in the communities surrounding the universities. Is there anything to that?
I actually haven't done what you're referring to or talking about, but what I can tell you for when we report our numbers, so on the website, we only report confirmed cases. And if you're just trying to do, and we've seen this happen with others that are looking at data from either what school districts are posting or what other people are showing for numbers, and we're not using the same definition. So you're trying to compare apples and oranges. For Maricopa County Public Health, when we count a case, we're only counting confirmed cases. And a confirmed case for us is either laboratory confirmed through PCR testing, not antigen testing, or that they can be epidemiologically linked to a PCR confirmed case. So the universities, especially University of Arizona, they're doing all antigen testing. So if you try to look at their numbers compared to, you know, Pima County numbers, I don't know how Pima County is exactly counting their numbers, but there may be a difference because of that. For us, ASU is doing a combination. They're doing some PCR and some antigen testing. But for the numbers we include on that daily case count for our new cases, those are new confirmed cases. And we do have cases that are what we call probable, and those are antigen cases. It's not very many. I mean, just want to be totally clear, for our cases, our probable cases right now in Maricopa County are about 1% of our overall cases. So our confirmed in cases are at 152,775, and our probable are 1,947. So it's a very small, but that could be just enough difference to make some inferences, like all the cases are around a university or something like that. Does that make sense?
Yes, yeah, no, right, and you're right. Part of it is ASU reports 370 cases from the campus, very generally, and then our daily number for the county might be 800. It just seems like that's a lot. If they are apples to apples. So that's great. I appreciate that. Final one, kind of a question for me, gets to our mission, our general public health mission here, which we've talked about before, which is what else are we seeing? Positive and negative, assumptions at least are, traffic deaths are down because fewer people are driving, but perhaps overdoses are up because of despondency and drug use and so forth. Against a general measure of untimely deaths, with COVID thrown into the pot, what is it looking like, or is there a measure that you follow for overall county health or mortality?
So this certainly came up a few months ago when we were seeing especially medical examiner cases. The difficult thing is we have the same data people that work on all of our COVID stuff that work on all of our other stuff. So it's going to take us a little time to unpack all of that. But what I can tell you is just overall deaths in all categories from 2019 to 2020 had increased. The medical examiner was able to share this with us in looking at some of our vital records, vital statistic information. What we haven't been able to do is to do a really good job analyzing and trying to figure out, are those deaths in certain areas, or is it, an aging population in Arizona? Like, what's kind of going on? And usually what it ends up being is a combination of several factors: an increase in our population, an increased aging population, and then, potentially some of these things like suicides, overdoses, increasing statewide. So just to let you know, we have seen some increases year to year, but to be able to give kind of a breakdown of what they all are, we're just not there yet to share that.
All right. Thank you. Thanks, Marcy, for staying on top of so many different things and being knowledgeable about it. Appreciate it. Thank you.
Any other questions for Marcy? Okay, Marcy, thank you. Just another informative report. You guys are doing a great job. And if we could go to Darcy and Ken.
Hello, Mr. President, members of the board. Today I'm here to speak about the enhanced regulatory outreach process for fee waiver code changes. I last came and spoke with you in July, where we then received, I think, input prior to going out for and initiating that process. Just a reminder that what we refer to the enhanced regulatory outreach process, I refer to that as the EROP process, and you'll see that in your presentation. Vera, you've got my slides in there, correct?
That's correct. As soon as you give the key, we'll move as you access, please.
Okay. If you wanted to bring up just the PowerPoint presentation with the first slide, that would be great. That's actually the slides that we did in our stakeholder meeting. Ken should have sent you he sent you a separate slide deck. Oh, there you go. Thank you. Okay, so we just wanted to give an update on where we're at in the process and then ask for approval to move forward. So a reminder that our EROP process was designed to promote consistency and transparency among regulatory departments during the rulemaking process. It allowed citizens to be engaged in the rulemaking process, and also they are able to follow the process online as we go through it. As part of this EROP case for fee waivers, we posted the proposed code changes online for public comment. We also, you can go to the next slide, please. So we posted it for comment. We also conducted an online stakeholder meeting on September 23rd. To date, we have received one online form submitted in favor of the item, and we also had one person log in to our virtual stakeholder meeting. The person who logged into the virtual meeting did not elect to comment either in support or against the process. Next slide, please. So as we've discussed in our previous meetings on this topic, this ERAP proposes to replace the word solely in the Maricopa County Environmental Health Code with the word predominantly. The strikeout is what the department wishes to delete from the regulation, and the word in caps indicates what the department wishes to insert into the regulation. This change would provide flexibility to the Board of Health that would address previous concerns expressed where the code is too limiting and some activities geared towards assisting the poor, distressed, and underprivileged did not qualify if their proceeds were not 100% allocated to these individuals or groups. There's also a minor change, as you can see towards the bottom on the right, where we're just renumbering a section that refers back to our fee table. Next slide. Okay, so this slide shows additional new language. It reads, applications for waivers of temporary food establishment fees will be processed on a first come, first served basis in accordance with Regulation 5A of this chapter, of Chapter 1 of the Environmental Health Code. The department shall only present a maximum of 25 such applications per event to the Board of Health. So in essence, the department would only accept the first 25 applications that we would receive per event, and it would be done on a first come, first served basis. This change would address the potential concerns with the number of applications increasing as a result of the definition change on the previous slide, and it would also potentially address the general trend and increase in number of special event applications that have happened over the last few years, year over year. Next slide. This slide shows new language that defines predominantly at 75% or greater of the operations or proceeds generated by the 501c3 charitable organization that provides relief to the poor, distressed, or underprivileged. The department anticipated that we will have a need to clarify what is meant by predominantly as we review these applications and make a recommendation to the Board of Health. As a result, we are proposing to add this definition to the code. Next slide. This expedited process, so we are seeking approval today to hopefully proceed with the expedited ERAP process. According to the county's policy, the expedited process can only be used if the following criteria have been met. A, the proposed amendment has been the subject of at least one stakeholder workshop posted on the county's website at least 2 weeks in advance, and one Citizens Board of Commission meeting. Also, a draft of the regulatory change was available on the ERAP website at least 2 weeks prior to that Citizens Board or Commission meeting and was forwarded to the Board or Commission at least 1 week in advance of their review meeting. And also that no comments of opposition to the amendment have been received from the public. And then lastly, it requires that a Citizens Board or Commission reviewing the amendment recommends approval, which would be what we're seeking today. So all of the criteria other than the last one, which is obviously your approval, have been met for this process. If we go according to this schedule, we will schedule the hearing, a public hearing at the Board of Supervisors, and we will advertise it as required with a tentative adoption date, probably around mid-January. And that concludes the slides I have for today. With that, I'm happy to answer questions, and then I would also respectfully request action today to hopefully move this item forward according to the expedited ERAP process.
Thanks, Darcy. Any questions for her on the proposal?
Don, this is Don Casano. I don't really have any questions. I just want to say this is going to make it much better for us, I believe, in sifting through all these waivers, because I think the way it had been in the past, it was black and white. There was no way you could get around it. And this gives us some flexibility as far as those applicants are concerned. So I like the changes.
Mr. President, Scott Seeley, if I could move adoption of the environmental services recommendation.
It's been moved and we need a second.
Don Casano, I'll second that motion.
It's been moved and seconded.
And Mr. President, Scott, again, just Darcy, one question technically about the proposal. So it talks about limiting or capping at 25 the number of exceptions or waivers per event. Our process also includes approvals for nonprofit organizations that actually have a facility. Is that right?
I'm not quite sure I understand that question. Can you clarify what you mean by that?
Well, I'll take one example, at least as I understood it, which is Boys and Girls Club that actually operates a kitchen, and hence they needed to get a waiver for the operation of the kitchen, which is not, it's not an event, it's not a fundraiser, but it's where they prepare food to be given to the children that come to their facility. If I understand that right. So
Correct. The change in the 25 would only apply to special event, which is temporary. We refer to them as temporary permits. What the Boys and Girls Club and many others have are actually annual permits, and those would be excluded from the cap on the 25. It would only be the events that would have the 25 cap.
great, thank you.
Thank you.
Any other questions? And can we do this by a voice vote, or do we need a roll call?
Can we put it in the chat?
No, the chat isn't part of the public record. Mr. President, you can go ahead and call for just a vote, and then
Okay.
as long as you call for opposition also. If there's no opposition, then it's just considered unanimous.
Okay. All those in favor signify by saying aye. Aye.
Aye.
Aye.
Opposed? Ayes have it. Darcy, it's been approved. Two. We'll go on to the next one.
This is Ken. Are you ready?
Yeah, Ken, let's go to yours.
Okay. Good afternoon, Mr. President and members of the board. Thank you for meeting today to review our fee waiver applications. You were sent the fee waiver application summary sheet, the staff report, and each of you were also sent a link that had all of the files for the applications and any correspondence that the department had with our stakeholders. So we felt that it's essential to process these agenda items because a few of the applicants have prepaid for their permits and they cannot get refunds until the board reviews and approves their fee waiver. Some of those applicants are food banks, and we know many of them need the funds right now, especially in light of COVID-19. And notwithstanding our EROC case with proposed changes to the Maricopa County Environmental Health Code just presented by Darcy, we respectfully request a vote of approval or denial on the 16 total fee waiver applications being presented to the Board of Health today. This quarter, we received 16 new applications for permit fee waivers. The applications were reviewed and we have determined that they all meet the criteria in our health code. And just as a reminder, again, only an operator of a charitable nonprofit establishment, which operates to provide relief solely to the poor, distressed, and underprivileged, may apply to the Board of Health for a waiver of permit fees. A waiver of the permit fee may be granted only to the operator of that establishment when they have a current 501c3 tax-exempt designation from the Department of Treasury Internal Revenue Service, and who demonstrates to the Board of Health that the payment of said fee will cause them a financial hardship. All 16 new permit fee waiver applications reviewed appear, in our opinion, to meet this criteria. And if the board has no questions and is comfortable with our staff review, I respectfully suggest a motion to approve fee waiver applications on the fee waiver application summary sheet, numbers P1 through P16.
Okay, any questions for Ken?
No questions from Paula.
No questions from Don Casano.
Great. Since there are no questions, all those in favor say aye. Aye.
Aye.
Any opposed?
Mr. Chairman, do we need a motion from somebody on the board?
Sorry, I skipped
And a
that part.
second? Yeah. I make a motion for approval of the fee waiver applications P1 through P16.
Second.
It's been moved and seconded. All those in favor say aye now for real. Aye.
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 Opposed? The motion is carried. Thank you. Any announcements by any of the board members? I think that's the next part on the agenda.
Mr. Chairman, it's Don Casano. I just wanted to say what I'm hearing from the people in the district that I'm representing is that they are very appreciative that the County Board of Supervisors continued with the mask mandate throughout the county so that there'd be less confusion for everybody, but I think it's what we need to do right now in light of what's going on out there with this virus. Thank you.
Thank you. I agree. Any other announcements?
Just a commendation, Mr. President, and this may have been mentioned early at the beginning, and I missed it coming in a little late, but if it wasn't noted, our colleague Robin Schaefer was recognized as one of the Capital Times outstanding women visionaries here recently, only virtually, unfortunately, but we're hats off to Robin for recognition and the work she's doing in the community.
Yes, that's correct. Congratulations.
Well, thank you. Thank you. Wow. Thank you for recognizing that.
It's quite an honor.
Yeah, it's quite an accomplishment. And actually tomorrow is the virtual, we had to all pre-tape our acceptance speech. And so it should be a great event. I get to just relax and watch it now. And I also have another, this is quite a year for me. I was planning on resigning from the Arizona Nurses Association as the executive director after 10 years, which I have finally done. My last 6 to 8 months were met with the COVID pandemic, and I have successfully transferred all of my responsibilities to our new CEO. However, I will be staying on contracted as the senior policy analyst for the Arizona Nurses Association. So still very involved in policy and the work that the Arizona Nurses Association is doing. Currently in the mask mandate space also, where we have a letter writing campaign right now because we feel so strongly that it's very important to wear masks to mitigate community spread during the next few months and possibly beyond. So thank you, and thanks for the recognition.
And Robin, you'll be staying on the board of health.
Oh, absolutely, yes.
Fantastic.
I have been a nurse for 42 years and totally committed to the board.
Well, we really appreciate having you here because you're another one of the voices that we depend on to provide us with really good information. Thank you.
Thank you.
Any other announcements? Okay, can I get a motion to adjourn?
Don Casano, I'll make that motion.
Second.
Been moved and seconded. All those in favor of adjournment, please say aye. Aye.
Aye.
Opposed? Our next meeting is January 25th, 2021.
Hopefully we will not be in a super situation of real negative information.
I hope not. Thank you all.
Thank you. Safe holidays.
Thanks.
Bye now.
Bye.
Thank you, everyone. The webinar will now end.